Welcome to EmCyte's webinar series. Join us as we explore the latest clinical insights and the science behind precision biologics.
Okay, good evening, everyone, and welcome to the fourth session of the Regenerative Edge EmCyte webinar series. I'm truly excited to have you with us as we continue exploring the frontier of the regenerative biologics in medicine. Tonight's focus is both timely and important: platelet-rich plasma therapy in men and women's sexual wellness. This is a field advancing rapidly with growing clinical adoption and new insights into both vascular and neural mechanism of the sexual function. I'm honored to be joined tonight by two distinguished leaders in this field: Dr. Anne Trong, an internationally recognized leader in regenerative medicine and sexual wellness. She brings extensive clinical experience using PRP and other biologics to restore sexual health and vitality, and her patient-centered approach has been widely influential in advancing this field. Also with us, Dr. Christopher Sandra, a board-certified physician specializing in hormonal therapy, regenerative medicine, and sexual health. He is a pioneer in integrating biologics like PRP into comprehensive treatment protocol and brings a powerful perspective at the intersection of the science and clinical practice. And you know me, I'm Dr. Sina Farzaneh, Scientific Director of EmCyte Corporation. I will be guiding tonight's session and contributing from both the research and product development side, particularly where science meets clinical application in biologics like PRP. Dr. Trong, would you like to start with a quick greeting?
Hello, everyone. I am so honored to be here, be part of this presentation with Tina and Dr. Sandra. And we hope to give you a presentation that will give you a clear view of what sexual health is about and why every physician attending here should really address it head on.
That's great. Thank you so much, Dr. Trong. And Dr. Sandra, please go ahead.
Oh, hi, everybody. It's Dr. Sandra here. I'm excited to be here and kind of talk about PRP for sexual dysfunction, particularly in men for erectile dysfunction. It's been highly successful and useful in my practice, not just from a clinical standpoint, but from a business standpoint as well. So I've had a lot of success with it, especially using the EmCyte system, and I'm excited to share what we've accomplished with this.
That's great. Thank you so much. As our usual plan, I will begin with around 10-15 minutes introduction to lay the groundwork. Then we will move to Dr. Anne Trong for her presentation. Mostly, she's going to talk about the women sexual wellness, and then followed by Dr. Christopher Sandra. After both talks, we will open it up for a live question answer session. Please feel free to submit your questions anytime in the chat. I will collecting all of them as we go. So I would share my slides and start a kind of introduction. Okay, can everybody see my slides?
Mm-hmm. We can see it.
That's great. Okay, so sexual health as a core part of overall well-being and quality of life. The World Health Organization define it not just in physical term, but as a state of physical, emotional, mental, and social well-being in relation to sexuality. When sexual dysfunction occurs, the impact can be profound. It can strain relationship, reduce intimacy, and contribute to anxiety, depression, and low self-esteem. Take erectile dysfunction as an example. It doesn't just affect performance. It often undermines confidence and partnership satisfaction. But the consequences go well beyond the bedroom. Sexual dysfunction can affect productivity, focus, and overall work performance. And on a broader level, it influences family stability and even community health. That's why sexual wellness is not just a personal concern, but truly a public health priority. So, as you know, sexual dysfunction in men is very common now. In a 10-year study of over 2,000 patients, the top reason for visiting were erectile dysfunction at around 41%, apparent disease at 18, premature ejaculation at 16, and low sexual desire at 10% among the men. In the US alone, more than 30 million men are affected by erectile dysfunction. Prevalence rises with age, about 40% of the men at 40, nearly 70% by age 70, and over half of the men between 40 and 70 report at least mild to moderate ED, which means erectile dysfunction. Overall, erectile dysfunction and premature ejaculation are the most common male sexual health problem today. If we consider the erectile dysfunction as the most common male sexual problem, which we are going to talk more about this tonight with Dr. Asandra, and also Dr. Trong would help us. Its causes are often multifactorial. It can be psychogenic, such as age-related libido decline or performance anxiety. Most cases are vasculogenic, arteriogenic causes like diabetes, hypertension, obesity, smoking, and aging impaired nitric oxide signaling and blood flow, while cavernosal or venous leak prevents maintaining rigidity despite normal inflow. Another factor could be neurogenic factor, including stroke, Parkinson, spinal cord injury, or surgical and diabetic, again, a kind of diabetic nerve damage, account for up to 20% of the cases. Hormonal issues such as low testosterone, thyroid or adrenal disorders, and again, diabetes further reduce vascular and neural function, and we can end up to erectile dysfunction problem. Other contributors include certain medications, trauma to the pelvis or perineum, and anatomical problem like Prurian disease gonna be another risk factors for erectile dysfunction. In short, ED arises from overlapping vascular, neurogenic, hormonal, and structural pathway, and often serves as an early warning signal of broader cardiovascular disease. Early cardiovascular disease could be one of the signs for that as ED, or it has a kind of vice versa. If we see the cardiovascular disease, most of the case we can see the ED and vice versa. So another common problem, and I talked earlier, it was the premature ejaculation, and its causes are often mixed. Psychological factors like performance anxiety, depression, and relationship stress are very common. It's also strongly linked with erectile dysfunction, and the two often make each other worse. Hormonal issues such as hyperthyroidism or low prolactin can contribute, while the urological side, conditions like chronic prostatitis, pelvic pain, or even varicocele are frequently seen. A structural factor including Changes in pelvic floor muscle can also play a role, which brings us to the next important area of discussion. And one of the things I really want to bring in this society as a new idea for this study, it's just started for a couple of the in couple of the clinics, but still we don't have that much data about that, which is going to be the pelvic floor muscle and application of the PRP for men in pelvic floor muscle, specifically for premature ejaculation, and also it could be for erectile dysfunction. As I just mentioned, pelvic floor muscle play a critical role not only in urinary control, but also in erection quality and ejaculatory control. Weakness, imbalance, or inflammation in this muscle can worsen conditions like stress urinary incontinence, erectile dysfunction, and rapid ejaculation. Now, here's the interesting idea. We know that PRP injections into the pelvic floor muscle has already shown a strong evidence for stress urinary incontinence treatment, helping regenerate tissue and improve muscle support. So, could the same principle be applied to premature ejaculation? By restoring the pelvic floor strength, improving local vascularity, and reducing the inflammation. So PRP may offer a novel regenerative approach to enhance ejaculatory control by this approach. I don't know, we would be discussing more about this with our guest speakers. So we also have, after looking at male sexual dysfunction, it's important to remember that these issues are just as common and often even more prevalent in women. Globally, about 40 to 45% of the women experience some form of the sexual dysfunction in their lifetime. US survey found 43% of the women compared to 31% of the men reported problems like low desire, arousal difficulties, or orgasm issues. The most frequent concern are low arousal, low sexual desire, difficulty reaching orgasm, and insufficient lubrication, each affecting roughly 1 in 5 women in midlife. Pain conditions such as dyspareunia and vaginismus are less common but can be deeply disruptive. These challenges shift across the lifespan, rising after menopause, but also present in younger women due to the stress and relational factor. So, and as we mentioned, lack of the sexual desire and arousal is very common. Desire starts usually in the mind, but for satisfying function, the body must respond with the blood flow, engorgement, lubrication, and sensitivity. When blood flow or nerve function is impaired, specifically in sexual organ, mental desire doesn't translate into the arousal or orgasm. That's why PRP or other regenerative biologic is being explored by improving vascularity, mostly lubrication and nerve sensitivity. PRP help the body match mental desire with physical response. In practice, injections usually for women for this specific purpose could be at clitoris and anterior vaginal wall to deliver growth factors where they can restore blood flow circulation and enhance nerve repair. That mechanism directly tied to arousal and orgasm. Apart from the issue of the desire and arousal, which are mostly linked to the proper function of the erogenous zone, women can also experience impaired orgasm and pain due to the urological and structural disorders. These are areas where regenerative medicine, specifically in this case PRP, may offer real benefit. So as you see here, the causes are broad. Conditions like vulvodynia, endometriosis, chronic pelvic pain can alter sensation and create discomfort. Vaginal atrophy and inadequate lubrication, especially after menopause, are also very common contributors. Structural changes following childbirth or surgery, as well as urological disorders and even psychological stress, further complicate the picture. So, but even when the pelvic organ appear normal, some women still experience dyspnea or vaginismus, highlighting the complex interplay of the nerve, tissue, and pain pathway. By promoting angiogenesis, nerve repair, and tissue regeneration, PRP holds promise and addressing several of these underlying mechanisms, improving both orgasmic function and reducing the pain. So just as an example, one of the major contributors in impaired orgasm or painful intercourse is vaginal atrophy, also known as genitourinary syndrome of menopause. It affects nearly 45 to 47% of the postmenopausal women, significantly impacting quality of life. It's driven by estrogen deficiency from the menopause or anti-estrogen therapy, leading to thinning of the vaginal lining, loss of collagen and elasticity, reduced blood flow and lubrication, and increased the fragility and pain during the intercourse. But how PRP in this case could help? The growth factors like VEGF, PDGF, in the PRP stimulate new blood vessel formation, improving vascularity and lubrication. FGF and TGF beta drive collagen remodeling, restoring the elasticity and reducing tissue fragility. EGF and IGF promote endothelial regeneration, thickening the mucosa for better protection. PRP also support nerve regeneration, improving sensation and responsiveness. Finally, its anti-inflammatory effects help restore a healthier vaginal environment. Traditionally, local immunotherapy has been the mainstay treatment, but now non-hormonal biologic like PRP and newer intravaginal energy device like shockwave are showing very promising outcome. So when we look at the pathophysiology of the most of the sexual dysfunction conditions, we see that the key underlying issues are poor blood flow, nerve damage, tissue fragility, and chronic inflammation. And based on all of the growth factors, cytokines, and equipments, I would say in the PRP, we could overcome most of these problems using the PRP. The only thing we need to consider is the right formulation, and Dr. Trong and Dr. Asandra are gonna talk more about these factors. And in my last slide, I read one of the most fascinating paper I've ever read in this field, and I wanted to share this paper with you. This study it's a kind of fascinating piece of the evidence on how PRP work beyond just blood flow. Aging leads to axonal atrophy, cavernous nerve degeneration, and reduced expression of the neurofilament heavy chain, which together impairs nerve conduction and weaken erectile signaling. It also contributes to a smooth muscle cell damage and prostate hyperplasia. both worsening the erectile dysfunction. This study also, it's in the kind of preclinical study, but it's very enriched. And because of the limitation of the time, I cannot go deeper about the details of this study, but just a 20-second summary. Mechanistically, the benefit comes from the PRP-rich growth factor based on this study. IGF-1 provides neuroprotection, helping preserve axons. PDGF supports Schwann cells proliferation and myelination repairs, and also TGF-beta stimulates nerve growth factors production and promotes axonal regeneration. This is one of the most fascinating study, and I highly recommend all of our audience reach out and check this study. It's open access. So sorry if it took longer. I'm gonna pass the screen to Dr. Trong, and we are gonna learn a lot tonight.
Okay. That was a fabulous presentation. I don't know if I can even meet up to that expectation, but I've learned something, and I took a picture of that last slide. That is awesome. I'd like to share my screen if that is okay.
So yes, yeah, you can now.
Yeah, I think you have to stop sharing so I can share.
Okay, so,
All right.
That's great.
Wonderful. So that was a good preface to my presentation. And if there is anything that I'm presenting that is duplicate, I'll move through it fast because we want to save time for questions. And I'm sure there'll be lots of questions. But what I want to stress, let me put this on presentation mode before I share. What I want to stress for the attendees today is that by attending this meeting, you are going to be at the forefront of regenerative health. What are you seeing right now? Are you seeing like a multiple, or are you seeing my one slide? Are you seeing one slide right now?
One slide and the next. Now, yes.
There we
Okay,
go.
now you're seeing one slide.
Yeah.
Oh, okay. Wonderful, wonderful. You're seeing one slide. Awesome. All right. So what I'm trying to say is by attending this webinar here today, you are going to be the pioneer of regenerative medicine for sexual health. And let's go ahead and start. All right, let's see. I don't know why I can't move it. Okay, here we go. So overview today, my talk is that why sexual health is good health. And we're going to go over the female anatomy and the sexual response. And then we're going to go over the biologic for female sexual health and how sexual wellness and sexual health is really a multimodality approach. So I want to start with that sexual health is just not only an organ. It is also, let me go back, it is also a component with physical health as well as mental health, and it's an interplay between the three. And that I'll stress this again, but the most important organ for sexual health is actually the brain, not the sexual organ itself. And studies have, this study in 2021 showed there are many benefits of good sexual health, good sexual energy that translate just beyond the bedroom. Sexual health, good sexual function in the bedroom, it can decrease stress, decrease depression, decrease pain, decrease heart disease, and decrease the incidence of cancer. Also, twice weekly relation decrease the incidence of MI by 50%. And that intercourse is actually moderate exercise, burn about 100 calories. It also increased longevity and increased sense of well-being, increased immune function, increased joy, increased bladder function, increased self-esteem and happiness, improved sleep. And sex is really considered moderate exercise. I'm not making this up. This is in this study, but this is why we talk about this, because sexual dysfunction is the only disease that affects the couple. If you are in a relationship, it affects two people, not just one. And so I'm going to be talking about female sexuality. And Tina covered a little bit. The prevalence of female sexual dysfunction is between 38 to 52% worldwide. And in the US, and this is important, age between 18 and 59 is 44%. So sexual dysfunction is not only for older women or postmenopausal women, it's also affecting women they're 18 to 59 years old, 44%. That is a lot. However, there's age-related prevalence pattern that if women is between 46 to 50 years old, it's about 23%, and that 51 to 55 is 45%. But when you're in postmenopausal or women that does not have a period for 1 year, it's up to 70 to 75% that experience some form of sexual dysfunction. And we'll go over what is sexual dysfunction. Well, sexual dysfunction for women it's a little bit more complicated than men. For men, it's like, is it ED or is it not, right? For women, you have about 5 categories, right? There's low sexual desire, which is the most common, affecting 22 to 38% of women. And then there's arousal disorder, which affect between 10 to 35%. And then orgasmic dysfunction, which affect about 10 to 45%, and lubrication difficulty, which affect between 11 to 21%. And then you have the sexual pain or dyspareunia affecting 7 to 15%. But guess what? These condition does not go away with aging. So if a woman has this when she is 18 or has it when she is 30, it does not get better with aging. So this is the only thing that for women, it does not get better. But a woman that has menopause symptoms such as like hot flashes, night sweat, and all that, it gets better. But the sexual difficulty does not get better. And so I want to stress that there is clinical distress versus dysfunction. When somebody has dysfunction, but is it distressing them in their life? Is it distressing them in their relationship and their quality of life? So we talk about any sexual problem for women is between 44%, right? But distress associated with the dysfunction that it means that it bothers them, only about 10 to 12% says that they are bothered by it. And this is the most important part that I find very distressing, and that the women, only 10% really raise this issue up with their healthcare provider. So that means that if they're having problem, if 44% of women having problem, and only 10% of the 44%, which is really 90%, are now suffering in silence and suffering alone, or they may not even know that this is a condition that can be treated, right? So that is a very sad data, I think. And Asina had talked about the sexual dysfunction is multifactorial. It's a physiology, psychology, social cultural issues, and interpersonal issues. That's why it makes it fascinating. And that I wanted to kind of stress to mention that there are risk factors that you should know as a provider when you're looking at your patient, and these health conditions are risk factors. Uncontrolled hypertension are more, women with uncontrolled hypertension are more at risk for sexual dysfunction than controlled hypertension. And 90% of women with sexual dysfunction have essential hypertension. So that's interesting, right? And then other risk factors that put women at sexual dysfunction: heart disease, diabetes, rheumatoid arthritis, chronic pain, cancer, and those undergoing cancer treatment, and gynecologic factors such as history of abortion, multiple pregnancies, and genital mutilation. And then lifestyle and conditions such as menopause, certain medications such as SSRI, tricyclic antidepressant, non-selective RI, beta blockers, diuretics, and ACE inhibitors. There's not to mention other lifestyle. It's like women that are more sedentary or more at risk, smokers, poor sleep, alcohol consumption, and also drug addiction. So let's just kind of talk about why are we talking about this, because luckily, there is a standardized questionnaire that is called the Female Sexual Function Index. It's a validated questionnaire that Rosen came out with, and this is like, I believe it was 2000. That's right, 2000. It's a validated questionnaire to assess different domain of sexual function that I had put out earlier: desire, arousal, lubrication, orgasm, satisfaction, and pain. And it's a long questionnaire, but I will give you access to it at the end if you give me your information, and I'll give you this questionnaire. So it's 19 questions, and if you score of 26 or less, then you are diagnosed with sexual dysfunction. And but I advise that you ask the question yourself and interpret the answer instead of having the patient do it the question themselves. So there is a test that you can measure with a patient, and then you can also give them a periodic this questionnaire to see how they improve with treatment. So let's go talk about female sexual physiology, talk about anatomy, nerve, vascular, and hormone. The last time, I don't know, you're like me, unless you're a gynecologist or urologist, last time I looked at female physiology and anatomy was probably in med school, because I'm a pain management. And so getting into this field, I really have to kind of really dive into this pretty deep. Let's talk about the external female anatomy, the glands. So the clitoris is really a small version of the penis. The clitoris has 8,000 nerve endings, twice as many as the penis. And then the clitoris also has the corpus cavernosum, which fork out, and I'll show you that picture. And then there's also the vestibular bulb and the labia majora and labia minora. So this is a picture of the clitoris. This is the gland, which is similar to the glands of the penis. This is the corpus cavernosum. This is also the clitoris, which is analogy to corpus cavernosum of the penis here. So 90% of the clitoris is actually hidden. What you see here externally, it's only the head of the clitoris, the glands, but the 90% of it is actually hidden behind the labia minora, which is what you see here. This is the corpus cavernosum. It forks out like a wishbone, and this is the bulb of the vestibule, also part of the clitoris, which is analogy to the bulb of the penis right here. So this is all behind the labia minora. And this the corpus cavernosum to here is it's a total of 4 inches. So it's not just the tiny little bulb that you see. And so here's the external, and here's just a picture of the labia minora removed. So this is the bulb of the vestibule I'm talking about, the corpus cavernosum here. And this is actually an erogenous zone for most female here, in addition to the clitoris. But however, the entire organ is the clitoris. And let's look at the anatomy of the female sexual organ. There's a vagina, and it is the muscle canal that is 7 to 10 centimeter in length. And then you have the vaginal wall, which produces lubrication. And then you have the vaginal expansion that happens in the inner 2/3, which lengthen and expand during arousal, which is called the tenting effect during arousal. And then you have the uterus and the cervix, which during arousal, the uterus elevate and retract to lengthen the vaginal canal. And there's a vascular response, right? And it's a vascular response of the vagina. You have increased blood flow changes. You have the clitoral blood flow, which increases 4 to 11 times more than baseline, which is a little bit less than the penis. The penis actually increases blood flow by 400% when it is erect. And then you have the vaginal blood flow, which increases 3-fold. And then you have increased oxygen tension, which increases the vaginal wall oxygen by about 4 to 8 times. Now, arousal for female response is a vasocongestion process. Then you have arterial dilation, which then relaxes the smooth muscle, which then allows more increased blood flow. And then you also have venous compression of when the labia where the labia is engorged. I mean, the vagina is engorged as well as the whole labia is engorged. You also have reduced outflow, which then compresses the veins. Then you also have tissue swelling as well, which result in clitoral erection and labia engorgement, very similar to the male response. So increased blood flow, the veins get compressed, but instead of getting a full erection, the clitoris get erection and there's labia engorgement. Let's talk about lubrication. So there are lubricants is secreted by the vagina, the Bartholin glands, the skin glands, and the cervix. So what is the Bartholin gland? The Bartholin glands are right here, which is right just underneath the introitus. And then here's the urethra, and the skin glands are the periurethral glands, which are very important for lubrication and in prevention of UTI. And there's also the neurological component of female anatomy. The brain region that is involved in sexual response is the hypothalamus, the limbic system, the thalamus, and the cerebellum. Now, men have this also, no difference. And there's the neurotransmitter system, which involves dopamine, which is released during arousal and orgasm, which is associated with pleasure and motivation. And then there's oxytocin, which is released during stimulation and orgasm, which facilitate bonding. And then nitric oxide, which is critical for smooth muscle relaxation and blood flow. And then you have vasoactive intestinal peptide, which enhances vaginal blood flow and lubrication. Then let's not forget the peripheral nervous system, which is the spinal cord. You have the sacral segment, and then you have the pudendal nerve, which is the primary afferent pathway, by the way. And then you also have the sacral segment, which mediate genital arousal reflexes, and then the pelvic nerve, which is the autonomic nervous system. Okay, so autonomic nervous system is parasympathetic, promote vasodilatation and lubrication. So you have to be in the parasympathetic mode in order for you to get ready for the sexual arousal response. And then you're in the sympathetic nervous system for moderate arousal and orgasm, but mainly more in orgasm. So it's a switch between, you start with parasympathetic first, and then you switch to sympathetic nervous system. And let's not forget the pelvic floor muscle as well, because they're very, very important, but oftentimes very much neglected. The pelvic floor muscle, such as the pubal coccygeus, is involved in orgasm. The bulbospongiosis surrounds the vaginal opening, contract during climax. The ischial cavernosus maintain clitoral erection and contribute to orgasmic contraction. And then you have the pubal rectalis, which is help in pelvic floor support during orgasm. Let's look at these muscles. So this is the ischial cavernosus that I talk about that help with the clitoral erection. And then the bulbospongiosis right here, which surround the labia as well. And the pubal muscle is actually around right here, which is not shown in this picture. So I'll skim over this. This has already been mentioned before. So we are all here because we want to find out how can regenerative medicine with PRP help with female sexual dysfunction, right? So platelets come from megakaryocytes. It has alpha granules, and PRP activates cellular response for angiogenesis, new cell proliferation, and migration of stem cells to the area and production of the extracellular matrix. So a study by Everett showed that, hey, this was done in 2023, that you need a minimum effective dose of 3.5 billion platelets per injection for soft tissue pathology. And the sexual organ is soft tissue pathology. So that means you need at least about 60 cc of whole blood, and you need to have platelet recovery at least 80 to 90%. And the EmCyte PRP system had consistently demonstrated a platelet recovery of at least 90% most of the time. So I'll skim through this, but essentially, this is the platelet-rich plasma layer right here, which is the white buffy layer, which then releases all of these growth factors, which really is produce more blood vessels and cell growth, right? All right, so we know how PRP works. But why are we talking about this for the female sexual system? Well, let's talk about the G-spot. The G-spot was first described by a German psychologist. And this is actually should be 1950. It's an erogenous zone found in the anterior wall near the urethra as well, and it's surrounded by erectile tissue like the corpus cavernosa. It's probably surrounded by the bulb of the vestibule. And is located halfway between the pubic bone and the cervix, 2 to 5 centimeter into the vagina, and it's part of the clitoral-vaginal network. So this is what this is sagittal section. This is the urethra, and this is the superior vaginal wall. Here's a vagina, and here is somewhere between here is the G-spot. But the G-spot, interestingly, is surrounded by urethral glands, all right? And it's also surrounded very near the skein duct, which I have right here. And so a schematic of the G-spot right here. And then also this associated with the skein gland, which is the female prostate organ, and the Bartholin glands, which are down in the vaginal orifice here, which help with producing lubrication. So I'll skip over this, but what this slide is saying is that PRP is safe to be injected in the sexual organ, male and female, because it does no reports of granuloma, infection, or any serious side effects, and that PRP flows into the tissue as a non-viscous liquid, and it is safe. And these are multiple studies that I have listed under the reference that demonstrate that PRP help in the sexual response area because of the growth factors in the cytokine, and it stimulates neogenesis, fibroblasts, and glandular proliferation with the skein glands, new neuronal growth, and also improve physiologic response, and also nerve sensitivity as well, and improve arousal and orgasm. So it's studied by Nito, PRP for intimate female treatment, where he did a prospective study looking at 68 women, age 32 to 97, and they have lack of lubrication and have female sexual dysfunction, just libido, arousal, and dyspareunia. He injected PRP 2 months apart, 8 cc of whole blood, which is very small, and then ends up with 4 PRP at 4 cc activated with calcium chloride. He injects into the G-spot and 0.5 cc's in the skein gland each, and 1 cc in the clitoral area. What he found, interestingly, was that 95% were very satisfied and 90% improved stress incontinence, and that only 6% did not improve, but that was overactive bladder. So this was what's called like the O shot that you hear about. And then Runnels did a study in 2014 that looked at 11 patients with female orgasmic disorder and hypoactive sexual arousal disorder. And he followed along with the female sexual function, and he injected 4 mLs of PRP into the G-spot and 1 cc into the clitoris, saw 71 improvement, and that is what is called the O shot. And PRP in this study here, in the 2024 systematic review, found that PRP reduces vaginal dryness, burning, and dyspareunia while improving tissue elasticity, which is big because this is the #1 symptom that women suffer with during menopause. And this study here that I listed here showed that it can be helpful for vaginal atrophy, particularly in breast cancer patients who cannot have hormonal therapy. And they did this with another kit. Dawood in 2018 did a review of the clinical uses of PRP, and from 2000 to 2017, and concluded that PRP is currently considered a new therapeutic modality for disorders that are refractory conventional treatment. So I want to go over this study that shows that PRP is effective for stress urinary incontinence for women, especially when it's injected into the anterior vaginal wall, which is the area that I just showed you right there in that picture between the urethra and the anterior vaginal lining. And this is improved for mild to moderate stress incontinence. And also, but there's studies that I've also put in the slides as well. PRP is also good for lichen sclerosis. We mentioned about vulvovaginal atrophy, dyspareunia, pelvic organ prolapse, endometrial and follicular growth. There has been PRP injection into the endometrium and the ovaries, as well as only been one patient that has had that. Also, PRP, there's a study by Prodromidu that showed that PRP helped with mesh pain. I wanted to mention this, that sometimes it's just not PRP, sometimes you can do microautologous fat as well. The study by Lai showed that injection of EmCyte improve sexual dysfunction in 20 women, and he demonstrated that with histological evidence of increased collagen production and neovascularization and estrogen receptor expression and reduced neuropathic pain. So I want to emphasize that there's specialized application too, because for breast cancer survivor, either undergoing chemotherapy or in remission that can have hormone, PRP for these group of women is a life-changing treatment modality. And so I want to show you my protocol for how I treat urinary stress incontinence or in condition of decreased lubrication and increased sensation in the for the female. So I will get out 120 cc's of whole blood and with the EmCyte kit, and I would spin it down to about 6 or 7 ml of PRP, leukocyte rich. I want it to be orange. I don't want it just to be amber. I do want some leukocyte in there. But before I do the injection, we would numb up the clitoris and the G-spot and anterior vaginal, superior anterior vaginal wall with lidocaine and 7% benzocaine called BLT cream, and also around the periurethral area where all the skin glands are. And then I would do the clitoris block with 1% lidocaine and about 0.5 cc ml. And the PRP is then activated with 10% calcium chloride at 5% volume. So if I was going to inject in 7 cc of PRP, then I would mix it up with like 0.4 ml calcium chloride. And then I would inject around 3 to 4 mLs at the G spot, and I inject 0.5 ml lateral to each skin gland, right? So a total 1 ml, and then 1 or 2 mLs in the glands of the clitoris. And then if a female has dyspareunia, I would inject the PRP in the area of pain, either the labia minora or labia majora. These are all the references I mentioned earlier. And I want to, and not the last slide yet, but I also want to stress that if you're a provider and you're treating women and you're seeing women, know that no woman should live with painful intercourse of a physical cause or dyspareunia. This treatment can be, it can be treated within days. And it doesn't even have to be with PRP. Yes, it goes quickly. You use PRP to inject in the area of pain, but you can even prescribe just topical hormone, such as estrogen, that will be life-changing for her. She will not have painful intercourse again. Women describe to me that every time they have sexual activity, it feels like sandpaper, it feels like burning. No women should live with that. So if you are treating women, just know there is a treatment for her. She did not have to suffer in silence as well. And I mentioned this earlier that the brain is the largest sexual organ, and that to treat sexual dysfunction is really just not treating the organ itself. It's really a multimodality approach. So I call it the 7 pillars of sexual vitality. It's all the S's, meaning stress relief or mindfulness, because the brain is the largest sexual organ. If nothing starts in the brain, nothing's gonna start down below the neck. But sleep is important, and so it's a good diet called sustenance, and I recommend the Mediterranean diet. And the senses, meaning mutually pleasurable senses, so focusing on sensation rather than just performance or orgasm or even erection. And social support and communication with the partner is important, and exercise is important, such as sport, high intensity interval exercise, and then have sexual intercourse frequency is also a treatment modality as well. So this is how I call it my multimodality approach to sexual restoration for men and women, where we really treat from the brain, addressing the emotional side with breathing technique and lifestyle modification, hormone replacement therapy, nerve restoration with PRP, as well as blood vessel restoration. So we rely heavily on PRP, but we also do shockwave therapy. We also do peptides. We also do supplements, and we also inject in Botox as well too. But we also stress heavily on lifestyle modification, just as the 7 S's that I mentioned earlier about diet and exercise and sleep and mind-body connection as well. So it takes a multimodality approach sometimes to just not just treat the sexual organ itself. So I want to end with saying that we're not just not treating sex, we're just not treating orgasm. We're really, in the end, it's about relationship, it's about love, it's about connection. It's something that is so integral to our well-being and who we are as human beings. So we're really treating something that is essential to all of us, important to all of us, but the patient does not know there is something wrong or there is a treatment available. So I want to thank you for being here and participating in my talk. So if you want a copy of the slides and the female sexual dysfunction questionnaire, scan this QR code. And I will email you the slides and the questionnaire, so you have it as a reference, and also a questionnaire if you want to print it out and give it to your patient, and you can use it as a monitoring questionnaire that when they come to visit, whether they're responding to treatment or not. All right, so that is the end of my talk.
Thank you so much, Dr. Trong, for that informative information, and I truly enjoyed, and I learned a lot. And now we have Dr. Christopher Asandra. Dr. Asandra, we are all ear, so we're waiting for your insight.
Okay.
I
actually have my slides here. Let me just share this real quick and let me know if you can see it. If it's coming up.
Yes.
Okay, sorry about that. All right, so I actually found my slides here. Okay, so PRP for male sexual dysfunction. I've been doing this probably about 12 years, 12, 13 years now, treating men for male sexual dysfunction, hormone therapy, and longevity. And we've kind of seen kind of a really big trend in this and kind of some of the new science that has come about. And this is just kind of the outline, how we're going to talk about it, the physiology, what causes an erection, why you get ED, current treatments and therapies, and the approach to the male patient at consultations, and then of course, PRP for ED. So, erectile dysfunction, there's different types of sexual issues that Sina mentioned, like premature ejaculation, Peyronie's disease, as we know about, which is curvature and scar tissue. And then there's anorgasmia, where some men just can't finish or have an orgasm. So what is ED? I guess, simply defined, it's a persistent inability to obtain or maintain. Some people just think it's about obtaining, but it's actually about maintaining an erection for a sufficient time for satisfactory sexual activity. In a male study, it showed about 52% of men aged 40 to 70 had some degree of erectile dysfunction. Smokers are obviously not going to be able to perform as well, as we know, obviously why. And about half of men with diabetes actually suffer from ED as well. In Australia, I just found a study here about 34% of men aged 40 to 69 have some erectile dysfunction. Seems a little bit less in the US, but it's actually responsible for about 20% of relationship failures. And only 1 in every 3 men seek advice and about treatment for this, mostly because they're embarrassed, or if they go to their doctor, they just get Viagra. And that's why, 20 million men, or I think it's even more now with all these accessibility to PDE5 inhibitors like Viagra. They've tried it and they become reliant on it. But we see a failure of it in about 40% of cases, and also a lot of side effects. So a lot of men are trying to seek other types of treatments now to kind of take care of the root cause of it versus a Band-Aid like Viagra or Cialis or all these, cool pills that you see advertised that pop up on your Instagram or Facebook feed now. So the cause of erectile dysfunction, we've kind of gone through some of these already. And this probably applies to men and women. Obviously, we have one thing I've seen a lot of is performance anxiety now. And I think one of the contributing causes of sexual dysfunction in men, erectile dysfunction, is porn. A lot of people, the accessibility to porn now, and the accessibility to be able to just watch it anytime, it kind of increases your threshold, right? So I tell men who have erectile dysfunction, take a porn break, don't watch so much porn, because you're going to need that level of stimulation, or watch something, or have to have, some really kinky stuff to go on to even stimulate you. So, and then there's depression. And what happens when you, kind of go into the drug section there too, is when you go to your doctor and you talk about erectile dysfunction, or you have depression, the first thing they do is they throw SSRIs or an antidepressant at you, versus checking your hormones. Maybe your hormones are off. Maybe you're going through menopause. Maybe men are kind of experiencing andropause. So, SSRIs are a big thing. All these other meds we kind of talked about earlier, statins. I mean, how many guys are on statins now? It's like everybody's on Lipitor and all that. And we know their statins can actually cause erectile dysfunction. And then, obviously they sell you the drugs on top of that to treat the erectile dysfunction. So it becomes this vicious cycle there. We have endocrine issues as well. Nervous system, obviously, if they have spinal cord trauma, MS, Parkinson's, neuropathy, all these can affect it as well. And then ever since COVID, we've kind of seen an uptick of stress with men as well. So vascular is obviously the most common type, as we see here, and that's just atherosclerosis. I always tell guys, if your penis isn't working well, something else is going on in the body, right? So either you have, it could be heart disease, it could be diabetes, but one of the first signs that, that you're not healthy, or blood flow's been impaired, or you're not really getting the vasculature and blood flow to every good areas where you're out of shape or whatever, is erectile dysfunction. So if something's going on down there, something else is going on in the body. So metabolic disorders like diabetes, hypertension, obesity, and obviously high cholesterol, and all that. And this is kind of the pie chart here of the causes of ED. Some of it here, I think endocrine's actually bigger now. I think it's, obviously we know it's still vascular, but I think endocrine's actually playing a bigger part in it now, just from what I'm seeing in my practice. So obviously this is the male reproductive system here. We have the bladder. Really what I want you to focus on is this area here. Let me just put a laser pointer here. Just kind of this whole area here where the vasculature is, and then back here as well. But that's really the part we want to focus on when it comes to reproductive. A little diagram of, just seeing some of the vasculature in the penis here, particularly in the corpus cavernosum. You have 2, and that kind of plays a role in terms of where we give the injections and how we use the PRP. But you can kind of see the blood is here and here, right? The blood vessels that support erections and kind of the tissue there are these deep arteries here that we want to repair, and also the microvasculature in there as well. So really those 2 areas. And then just remembering about erection physiology, it takes some stimulation. It's not a sympathetic drive. It's actually, as we know, point and shoot, as we remember from med school or whatever, it's parasympathetic. So when you're relaxed, you're able to achieve it better, and you get the release of nitric oxide, and that's where Viagra works to relax those smooth muscles in the arteries. And that's how you achieve the erection. You get the arterial dilation. The penis fills up with blood, et cetera, and then you get venous compression. So when it fills up and expands, it's also blocking the veins from getting the blood flow back, which helps with the erection as well. So if you have overstimulation of sympathetics and drives, it can actually cause constriction. And what happens with that, if you're too, performance anxiety and you're too nervous or whatever, and you get that sympathetic drive, blood flow is going to go back to the major organs, your brain and your heart, and the parts where it's trying to preserve, as if it was fight or flight. So you get detumescence, and that's when your penis kind of shrinks. And that's where I see a lot of guys suffering from too, is with a lot of performance anxiety. This is just kind of the pathway here, how Viagra works, nitric oxide, PDE5. This is actually the area where Viagra works as well. and a couple of the other medications that we use. Just another kind of a view of here, what happens during the erection, kind of what you can see the blood filling up here into that area here, but it is those deep arteries here in the corpus that we kind of see where we want to, attack and kind of help the blood flow and repair the tissue and nerves there as well. So kind of a cool little view here of how the erection happens and what happens and what it looks like during an erection there. Just the major arteries that go here, you can just see here, I just kind of listed them here. It's kind of an old textbook vascular scene there. So first line therapy, I always tell guys, you got to have some lifestyle modifications. I think it's a blend of all these, right? You got to start exercising, eating right again, adjusting your medications that you're taking. So if you're taking a lot of crappy medications that could be affecting it, really need to look at that as well, as we talked about earlier. Second to the oral agents, I don't necessarily agree with this. I still think, this is just kind of what the textbook says. And, you should start using Viagra next and then calcium, counseling, and then vacuum pumps on top of that. I don't know if I necessarily agree with that. I really try to get my guys to focus on number one first, and then, use something like regenerative, like PRP. Third line treatment, I actually like this one a lot here, is it's basically the penis shot, if you will. It's a bunch of trimix and a bunch of medications put together to cause vasodilation, to cause smooth muscle relaxation. It's almost a guaranteed erection when you use this. And guys like it because it's given locally. It works almost immediately. You don't have to think about it. Viagra, it takes stimulation. It takes, you get side effects, stuffy nose, upset stomach, headaches, backaches. I hear that from a lot of guys, and they don't like it. So ICP, as we call it, you're injecting right into the penis. You're going to get an erection, but we have to also worry about priapism. So that's the big thing, is we've got to worry about, it lasting too long, or if it's too powerful, it may not come down and you end up in the emergency room. Fourth line treatment, hopefully you never get here, but a lot of guys have this as just a penile prosthesis, that they get implanted by a urologist, and they have to pump it up and do all this stuff beforehand. It's not really sexy when they, before intercourse to kind of do all that, but it does work. But there is a failure rate with them too. If it fails or it breaks, it's difficult to replace, or not at all. That's kind of like what it looks like on the inside. So hormone replacement therapy is kind of what I specialize in. And this is really what I love about what it does for men. It increases their libido. You get increased pelvic floor strength. It really helps them they get better blood flow there. They start telling me they have better morning erections, which I think morning erections are almost like exercise for the penis. Like we'd exercise in the morning, well, you should be waking up with an erection as well. There's different types of ways to do it: topicals, creams, gels, injections. I prefer the pellet therapy in my practice. That's what we use. And then secondarily, the injection therapy. Then we have the shockwave therapy. This one I usually combine a lot with PRP, a lot of guys are hearing about the shockwave therapy. So they're doing shockwave therapy more now. And I usually use it in conjunction with PRP, because we're really taking a regenerative approach here, right? We're really focusing on the vasculature, destroying plaque, improving blood flow, improving nerve endings and all that, and really improving neovascularization, if you will. So it requires multiple treatments, but it really is a way to, help guys start, taking care of the problem at the beginning, and then incorporating that with the first line therapies like exercise and lifestyle improvements, weight loss, et cetera. They really see good results with that. Then there's some stem cell therapy that we're starting to see kind of on the rise now as well. I've kind of seen some mixed results with that. I just want to go through a quick thing on the consultation that I do with guys here. It's really, the general practitioners are the first point of contact. And they're usually dismissed, or they're given pills to fix their problem. It really requires like really strategic assessment of the patient, counseling, follow-up. I mean, empathy towards these guys, because a lot of them are defeated. They've lost their relationship. They can't perform as well. They're really not feeling good when they come into you, and they suffer from this. So it's really, but I think the good news is we can tell them that ED is treatable. It is, we can treat it now, and we can take care of the problems at the root cause of it. A lot of questions that I ask them: are you depressed? Is it causing depression for you? Are you worsening it with SSRIs that you've been given by your primary doctor? I review their medication lists and try to reduce or substitute them. Maybe tell them, your cholesterol is so low now. Why are you taking a full statin? Maybe you just need half a statin. You don't need to take a statin. A lot of times the statins are the root cause of it, and they don't feel good after they start that. I always tell them encourage cardiovascular activity, weight loss, diet. Really what I tell them to do is start exercising more to increase blood flow below the waist. This is key. I tell them you got to start doing more lower body exercise, because if you're increasing blood flow below there, it's also getting to the penile area as well. So a lot of my guys start exercising, they do light weights, and it doesn't have to be heavy, but increasing their cardiovascular, doing air squats with light weights, and they notice they have better erectile function with that, especially when you combine it with other modalities like shockwave and PRP. I always encourage to have the spouse join, because a lot of times the spouse doesn't understand this. They're like, you're not attracted to me anymore. Is that why you have ED? You must have erectile dysfunction or you can't get it up because you're not attracted to me anymore. So I want the spouse to join so they understand that this is not necessarily due to that. It's actual something that men suffer, just like women suffer through menopause, and they may have dryness and painful intercourse. It's the same thing with men. It can happen to them too. And then I asked the patient, has he lost a lot of size? Because a penis, like any muscle in the body, if you don't use it, you lose it. I always flex my arm and I say, if I don't use this muscle, what happens to that muscle, right? It's going to shrink over time. And if you don't use your penis for years, you're going to notice it gets atrophied and it starts shrinking. So that's one thing I ask my patients as well. And I encourage them to start getting better blood flow there with treatments. Are you getting morning erections? When did you start noticing that you started having the ED? Did you have another health condition? Were you diagnosed with diabetes, heart disease, whatever at that time? And then also the degree of the erection. When you say you can't get an erection, what do you mean by you can't get an erection? Is it you can't penetrate with it? You can't last with it? So is it penetrable? Is it hard enough to penetrate? And most of the time it's not, or they lose it. They get it up for maybe a few seconds and then it goes down. And just to compare it, I'll say, so when you get an erection now, I want you to compare it to when you're like 18 years old. When you're 18, that was an erection. Are you getting that amount anymore? And 90% of the time it's no, I don't achieve that amount of an erection anymore. Ask them how it's affected their current relationship as well. I always check for, when you do the physical exam, any penile abnormalities, lesions, bruisings, curvature, if there's atrophy there. And I don't know if it's, smaller for them or not. So I'll ask the patient, have you noticed a lot of loss of size here, especially at the base? You'll see a lot of these guys at the base of the penis. It's kind of just very atrophied and skinny, and then it gets kind of thicker. So that's really key there. Are they circumcised or uncircumcised? To see if they, just to kind of document that on your physical exam. Prostate, sometimes they do that, but most of the times they've already had a prostate exam exam with their regular doctor. So with PRP, it's kind of the goal of PRP obviously is to improve blood flow, right? It's neovascularization and angiogenesis, which means improving the blood flow there, creating new blood vessels, and getting those blood vessels to heal. There's strategic areas on the penile shaft, as we saw in the pictures earlier, that I target. You want to induce somewhat of an inflammatory response to signal the body to heal that organ, just like PRP does. And you really need to use quality PRP to achieve those positive results. Again, I use them in combination with other therapies just to give guys the best shot at being able to function again. This is kind of the mechanism of action. I think Sina kind of talked about this earlier. We got angiogenesis, we have neuroregeneration. We also have smooth muscle and collagen remodeling. And that's why we use it for aesthetics as well. But it helps helps with the smooth muscle and the collagen remodeling there. Also taking away scar tissue as well. We inject it into areas like if they have Peyronie's disease, we like to inject the PRP there to improve the scar area. We use that in combination with some shockwave therapy as well. Then obviously over time it has an anti-inflammatory and healing effect with PRP. So the results and benefits that we've seen with it is obviously what I said earlier. A lot of guys tell me their size and length comes back. I think that's just from better blood flow and improvement over time with like exercise, as I call for the penis. It helps increased appearance, helps with Peyronie's. They get some increased sensitivity from the neurogeneration there, increased stamina. They get more frequent morning erections. And then they get a better response to ED meds as well. So they'll say, I'll take a Viagra after PRP, and I notice I get a better response now with it. Some contraindications I just go through real quickly here. Obviously, if they have herpes, you see an active herpes infection or sores there, I kind of wait off and tell them to have that go down first before we do the PRP. Obviously, if they have a penile prosthesis, they have really bad coagulation disorders, the platelets, if they have a Foley, obviously, or the current UTI. Sickle cell patients, I tend to not do this in either. And if they have severe anemia, and you may want to consider if they're on some anticoagulation therapy, if you want to do the procedure that day, or maybe they should hold off a day because you may have a lot of bruising and bleeding with the procedure. Ideal candidates for mild to moderate, these are just mild to moderate are your best responders, especially if they poor responders to Viagra. And then men seeking regenerative versus symptomatic approaches, like just throwing pills at it. Regenerative medicine and longevity medicine is getting more popular now. So those are really your ideal candidates. Less predictable results we see, obviously, if they have severe ED and they just, you've got your really old guy there and they have advanced vascular disease or fibrosis there. Post-prostatectomy with complete nerve transection, it may be more difficult with them. They may end up having to use the injectable therapy for that. And then significant psychogenic ED, those guys are difficult to treat there. If they have a lot of psychological issues there, that they're just not going to be able to get an erection from the beginning. Comparison between the different methods that we were seeing earlier here, like the Priapus shot, the P shot, as we heard, it was that was the Runnels thing. They use any PRP system. They're using kind of a test tube, and you're not really getting good quality with that. And then, you just do 3 injections along the penis shaft, and then you do it in the head of the penis. I'm not sure why they like to do the injection in the head of the penis when there's no vasculature there. Maybe just for sensation or whatever. I guess you could stick some there as well. But if I'm getting that good quality PRP, I really want to focus on where the vasculature is, which is in the shaft. I use only the EmCyte system. I do about 4 to 6 injections, depending on the length and the anatomy of the patient along the shaft. It results in better activation and damage there to start signaling a healing process. Again, I don't do any injections at the head of it unless they ask for it because of vasculature. I don't use calcium gluconate or chloride to activate it. We found that if you use a small gauge needle, I usually use a 31 gauge needle, the small one, because the sheer force of the PRP going through that, you're activating the platelets already. So I don't use it. Some people do, that's fine, but I tend to not use it, and we get great results just using the pure PRP. I don't add any additives to it at all. I just use the pure PRP. No bicarb, no lidocaine, any of that. It's just the pure PRP that we use for it. And I use a 60 cc kit. I get about 8 to 10 cc's of PRP from that. I usually use about 8 mLs, and I do about 4 shots on each side. A BLT cream applied to the shaft of the penis. Some people I'll do a penile block on. It depends on the patient. I tell them it's usually not that uncomfortable. We usually have them numb up for about 20 minutes with the BLT along the shaft. And then I really have them put on a glove and just massage that BLT cream into their penis so that they're really numb, and just warn them that they're going to be numb the entire day after that. You may want to use a penile pump. You may have to do that if they're really obese, to kind of extract the penis and pump it out and get it out before you do the procedure. Sometimes they'll use a little Valium if they're really nervous about it. I mean, they're about to get 8 shots in their penis. So, sometimes they may need that, or I'll use Pronox and nitrous oxide laughing gas to kind of help them too. It takes about 15 minutes total. Make sure they have about adequate anesthesia. Clean each side of the shaft. I just use a chlorhexidine or betadine, and then do the procedure. I try to pull out the penis as much as possible to visualize it. Sometimes I'll give them a little dose of the ICP, which is the injectable medication to induce an erection, just to get it out so I can see the better anatomy. I'll just give them a tiny dose of that just to kind of what we call plump up the penis, or kind of give them what we call a chubby. So I can hit easier, especially if they're smaller, just to have a larger target area there. And then I inject the corpus cavernosum with it. I use about 1 ml per injection site, 4 on each side of the shaft. It should flow easily. If it's not, then you probably either pierce too deep, hit scar tissue, or something else is going on. I don't go that deep because if you go too deep, then you obviously hit the urethral meatus sometimes, and they can have blood there. But these are the injection points that I usually do along the shaft there. Again, I try to get a lot at the base of the penis and then kind of work my way up from there. I always start medial, or not medial. What's the word? I don't do distal first. I kind of do it more proximal. Then I work my way distal. So I start down here and then kind of work my way up this way. Procedure continue. You may want to have them pump after that. You can have a penis pump that I usually give them afterwards, and just kind of circulate the PRP there. And they're supposed to do that continuous for like about a month or month and a half, or 10 minutes a day. Just kind of helps them anyways. There's going to be some bruising, especially if you're pumping. You're going to get the injection site's going to pull blood to that area. So I always warn them about some bruising after the procedure. Maybe some soreness as well, but I really don't hear guys complaining about that. They may pee a little blood if you pierce too deep. So just be careful of that. You can usually resume sexual activity in 1 to 2 days. Most guys don't have any issues with that. And then if they're on injection therapy, you just have to warn them, if they're using the injection therapy to induce erections before sex, just let them know they may have to reduce their dose, because now that they're healing and the PRP is working, they're going to have a higher chance of priapism when using that type of therapy. Treatment frequency, I usually tell the patient they need about 3 sessions usually. spaced about 2 to 4 weeks apart. Most guys wait a month or so, and then we just do about 3 consecutive ones, and then a maintenance one every 6 to 12 months after that as a booster, just to make sure that keep the tissue healthy, et cetera there. We're starting to see now, I'm starting to combine it sometimes with exosomes now. I haven't done it with stem cells, but I definitely use it with shockwave therapy. We still need some randomized control trials for this to kind of, what is the standard dosing and preparation and long-term efficacy? Well, this is what I do. Probably Dr. Trong and other doctors don't do it, may have some modifications in this. But personalized regenerative medicine is really key. It's potential because you really have to tailor it based on the patient. You can do these types of treatments, but what if their testosterone's low? What if they're on all these medications? You really got to focus in on the patient and find out what's causing their ED, right? Are they out of shape? Is it their hormones? Is it their meds? Is it whatever it may be? But you really need to take that personalized, tailored approach to find out the best ways to treat them for ED. But obviously, we know a lot of it has to do with vasculature. So that's why I think PRP is really one of the great treatment for erectile dysfunction and sexual dysfunctions in general. That's all.
That's great. Thank you so much, Dr. Asandra, Dr.
Thank
Trong.
you.
And just a comment regarding to both of your presentation. There are lots of variables in the PRP, and based on how we prepare the PRP, how we process the PRP, we can change the properties. We can enhance some properties or decline some others. For example, it was an idea and a kind of topic among the Society of Sexual Wellness experts regarding to preparation of the PRP using different anticoagulant. So we know one of the reason of using the PRP for this specific practice, this specific field, is increasing the blood flow by vasculogenesis and angiogenesis. One of the key factor can influence a lot in this specific target, is this specific aim, as the anticoagulant. So in EmCyte, we use the sodium citrate as anticoagulant, but other systems that are using ACDA. One of the big difference between the ACDA and the sodium citrate is the influence on the angiogenesis and vasculogenesis. Based on several studies, they showed the ACDA can hinder the VEGF function and endothelial cells migration and proliferation, which is essential for sprouting, for angiogenesis and vasculogenesis. Even simple things like anticoagulant, which is both of them, ACDA and citrate, both are very common for preparation of the PRP, but based on the purpose, we are going to have angiogenesis and vasculogenesis. Changing the anticoagulant can increase or decrease the outcome and efficacy of the PRP for that specific aim. Okay, is there any question? Please.
Can you stop sharing so that way we can our face will be on the screen when Chris. There's a button that says stop sharing. Right now you're muted.
Sorry, I'm trying to figure out how to stop the sharing.
It's a red button. There's like a red button that
Okay.
you'll see in the red button. Sometimes it's on the upper left, sometimes it's on the upper right. So it'll say go to Zoom, it'll say button and stop sharing.
Okay, got it. Recording my screen. I'm gonna just
there you go. We got it.
Sorry about
that.
Okay. That's great. Okay, so if there is any question, please send the question through the chat. I'm able to see the question, and I will read the question for our panelists. So yeah, it seems there is no question. Oh,
I see something pop
okay.
up.
So yeah, Dr. Beata Teralik, she maybe not a question, but just a comment that at our clinic for ovarian rejuvenation, we also active PRP mechanically. That's good. That's good to know. Yeah, Dr. Beata Trelick, as one of our doctor, she is OBGYN specialist, and we ran the webinar with her in our last session in the reproductive medicine. So I think there is another question.
That's very interesting about ovarian rejuvenation. But what I noticed was that Dr. Sandra doesn't activate with calcium chloride. I do activate with calcium chloride. I mean, I also treat a lot of ED as well. And I use 240 cc's of whole blood when I do an ED treatment. And we would inject in 20 cc's of PRP volume as well. But I would treat the guys that have prostatectomy, and I would treat the severe cases as well. But I activate my PRP, both female and male. But what's interesting is that he gets result, I get result, and I think it's what I see what your comfort level or what you've been trained. But what has been kind of the debate about activation and no activation with PRP, Sina?
So, okay, so I'm the fan of non-activation, but regarding to based on the experience for specifically for sexual organ, activation could minimize the pain and soreness, but you need to immediately inject. There are a couple of different scenarios. When we active the platelet, we actually start the degranulation of the platelets, and we start the platelet to start to release the growth factors, cytokines, and blah, blah, blah. One of the growth factors which can be immediately released upon the activation is the TGF beta. The half-life of the TGF beta is very short, it's minutes. And when we activate the PRP, if we inject later and it takes time, so maybe we lose some of the functional TGF beta. In some case, maybe we don't need TGF beta, you know. For example, if we want to treat the scar, so for a scar, TGF beta is harmful because it increases the collagen synthesis, and we don't need collagen synthesis. In that case, we prefer to minimize the collagen synthesis, specifically for hypertrophic scar. But in some case, maybe we need TGF beta. That's why it's better don't activate and lets the body, based on the presence of the collagen, which is one of the most strong agonists for the platelet, lets platelet get activated because of the collagen within the tissue. But you know, these simple difference, activation and non-activation, could change sometimes based on the target. If we want TGF beta or we don't want TGF beta. Another growth factor with a short half-life is the VEGF, which is essential for angiogenesis. The VEGF half-life is around 20 minutes. So if we activate and then inject 30 minutes later, maybe we lose half amount of the VEGF, functional VEGF. You know, when you go through the literature, specifically in vitro studies, they show, oh, we have VEGF, TGF beta, or other cytokines consistently released for a couple of days. Yes, which is true. With ELISA, you could measure them, but I would say they are not bioactive. They are not functional. You have the TGF beta, you have the VEGF, but it's not functional anymore. And another thing I wanted to ask, get your idea about that, since we know for estrous urinary incontinence, platelet works very well now, specifically if you inject through the pelvic floor muscle, specifically in women. There is an idea I saw recently in Egypt, I think, in Kuwait, and I think in Thailand. I know just these three. They started injection intrapelvic floor muscle for PE, because the idea
Mhm.
probably comes from Kegel exercise, which helps for premature
Mm.
ejaculation. And if we
Yeah.
could, with the biology, strengthen the muscle in that area, maybe we could at some point help for premature ejaculation. Have you had any experience regarding to that, or do you have any comments for that? Uh, I guess it should be very painful injection, but I don't.
Imagine. I
Yeah.
don't inject in that area personally. It's just like you said, it's a very sensitive area. One thing I do encourage men to do, besides we notice that when we put them on hormone therapy as well and testosterone, they tend to get better. Their PE is reduced with hormone therapy. I've noticed that. Secondly, when they exercise more, right? And I said exercise below the waist, squats, anything that's using the lower body exercise, you're strengthening the Kegel muscles there as well, right? And the pelvic floor. So that's one thing I encourage men to do always when it comes to PE or ED is just you got to start moving your lower body and start increasing blood flow there and developing muscles there and strengthening everything down there as well.
I actually do inject the pelvic floor by ultrasound guidance because I also do MSK. So I use ultrasound guidance. I will use a curvilinear probe and will actually inject there. If I feel that the pelvic muscle is very lax or weak, and especially I would do that in men with prostatectomy. I would do that in men with metabolic disease, such as having comorbidities of diabetes and obesity and high cholesterol. Yeah, and we would do that. We also inject into the prostate, which is a very easy injection under ultrasound guidance. Out of plane, of course, but the prostate is literally just about 1 centimeter just below the perineal area. Very easy injections. We have seen great result with PRP, and I think you mentioned that for benign prostatic hyperplasia in reducing nighttime urinary symptoms. I don't do it in everybody. I do it for some. I do it a lot for women with dyspareunia. So oftentimes dyspareunia is really due to a more spastic muscle in the pelvic muscle area rather than laxity. In men, is more due to weakness and laxity, but in women is really more due to more spastic muscles. So different approaches for a different indication. That's what clinical medicine is all about, right? It's not just a cookie cutter formula. You customize it to the needs. And I wanted to address Dr. Paul's question is that I don't use laser, but I
So,
use
sorry for
focus.
interrupting. Would you please read the
Oh yeah, right.
because
The question is, yeah, I forgot that not everybody have access to. So Dr. Rowan Paul asks, is anyone augmenting with class 4 laser, and what are the most common peptides that are used? And so I don't use class 4 laser. I use the focus shockwave. So before I inject PRP, and either for male or female, we will prime the area with the focus shockwave. And first, we use a store. And for female, we would do the clitoris area. We would go into the whole labia majora, the whole vulva area. And then we also will also target the anterior vaginal wall. And we would do that around 0.15 intensity, and a total, I believe, 5,000 shots. For men, we use 7,000 shots, and for men, we target the penis, the base of the penis, the prostate, the pelvic muscle, as well as the neurovascular structures in just above the ischial tuberosity. That's about 7,000 shots. Ask the question about peptides, I sometimes will use PT 141, but I have more patients getting side effects from that. has a nausea and vomiting more than even beneficial. So I'm using less and less of that. Sometimes I will use BPC 157 to accelerate the healing a little bit more in patients that I know that are metabolically not at optimal state for healing. I would do that in some patients, particularly diabetics or in patients that has had cancer treatment before, particularly in prostatectomy. Now, I do see a lot of severe cases in ED cases where they had prostatectomy and or they had like nerve damage or even Peyronie's disease as well. So some peptide, but a lot of time it's really more regenerative using PRP and shockwave and now Botox. Now, Chris, do you use Botox for ED?
I haven't. I probably need to learn that from you, Dr. Trong. That's awesome.
That's my go-to. That's my go-to.
Really?
I've been doing this in 2023. Yeah.
One
Wow.
question regarding to the peptide I wanted to ask. So if you want to compare the peptide with PRP, which one is longer lasting?
Well, I don't think you can look at it like peptides are kind of temporary. The PT141 is temporary. I usually call it the weak.
Botox, where it says.
Okay, sorry, Dr. Trump.
Which one is long lasting compared to another one?
Right. So Botox, according to the study, there was a study that came out in June of 2023 out of Israel, and another one that came out of Korea. So what they found is that this is for ED that has failed PD5 inhibitors like Viagra, Cialis. What they find is just injecting Botox alone has actually reversed their ED, and they're able to have erectile function again. If they use 50 unit of botulinum toxin A, which is Botox, they will see improvement in their ED at 6 months. But if they use 100 unit, they see improvement in their ED at 9 months. And so that's just Botox alone without PRP. So after I read that study, I said, well, I'm just going to add Botox. And how Botox works is that it relaxes the muscle. It relaxes the corpus cavernosum. And so when the corpus cavernosum is relaxed, that's how actually Viagra and Cialis work, right? Because it releases nitric oxide, it increases cyclic GMP, and that's how the smooth muscle is relaxed. So it acts like a continuous Viagra on the penis, the muscle. So the muscle is continuously relaxed. So it's easier for a man to get an erection. And especially if a man has some type of performance anxiety, or if he even ED. So it's already set the stage for relaxation of the corpus cavernosum. So it makes sense, but emerging studies are coming out also saying that the Botox is also helping with neurogenic activation as well, to the neurogenic regeneration. So for me, it just makes sense to combine that with the PRP. So, our protocol for ED is that we do 240 cc's of PRP with 20 cc's of PRP injection into the corpus cavernosum, and then 100 units of Botox and focus shockwave, all done at the same time with different syringes, of course. We don't mix the Botox with PRP, but do different syringes. I don't do as many injections as Dr. Asandra. I actually do 2 on each side of the shaft, a total of 4. And I agree with you, I don't do the glands as well. But I do activate, and I inject with a 27 gauge half-inch needle. But I put in 20 cc's of PRP. We would do the PRP first, then we would do the Botox second, but the shockwave is done first before all that.
I would say I'm starting to see, people aren't just coming in for PRP. They're not saying, I just want PRP. It's usually they want other types of treatment. They're going to want the shockwave, and I usually incorporate the two together. So it's not just, I hardly have any guys coming in now just saying, I just want PRP. And I always tell them you're going to have a better shot if you do, shockwave and other types of modalities with the PRP, not just PRP alone, obviously.
Yeah, it's still regarding to the Botox for blood flow. That makes sense for me. It increased the blood flow immediately, and it could be even faster response than PRP. but PRP could be more long-lasting, which is more regenerative than Botox.
Oh, definitely. No, definitely. I've been doing PRP to the penis since 2012, and I definitely see a longer benefit of PRP before I even start doing Botox. I just like to get these guys and a faster result. And what's interesting, if you combine the Botox and Shockwave and the PRP together, they actually get result in about 5 days. Most of these men are starting to see morning erection and firmer erection within 5 days. So I just want them to get a bang. So patient come to see you because they have ED. They just want to get erection again. They're not going to tell you what treatment modality to use. Use that the clinician will offer them what you feel is most appropriate for them. So we bundle it together. We don't let the patient choose. We say, well, this is the ED package. This is what you. But that's my protocol. So my protocol is more aggressive and quick result at this time. Okay. I think we have another question, right?
Yeah, there is a question from Dr. Turalik again. Question for Dr. Tron. Do you use it for patient with endometriosis?
Oh, PRP? No, I don't. But I think the reason why is because I like to stay in my lane. If I'm a gynecologist, I would certainly consider doing that. Because you would have to inject it in the endometrium, and I just don't feel it is in my scope of practice, of my specialty to do that. But I certainly feel that it definitely can help. I don't think it'll hurt. Come on, it's your own anti-inflammatory.
So that's why she asked that question.
Yeah, no, I definitely think if you have the skills, that's your specialty. Definitely consider that. I believe there was a study that did use PRP as for endometriosis. I don't know. I don't see why it wouldn't help at all.
And one question for Dr. Asandra. You mentioned you use the PT141. So it works for both men and women in a same level, or for men it's a little or not little less effective?
Well, I think when I use PT141, it's going to be different for men and women in terms of, like, for women, it's more of a libido stimulator, I think. But like Dr. Tron was saying, there's a lot of side effects like nausea, flushing, stomach ache. So what I tell them to do is really start at a tiny, tiny, tiny dose first, and then kind of work your way up. It's supposed to be 1 milligram. I tell them start at like 0.25 milligrams and see how they feel with that. And they do say it's definitely libido arousal. We kind of call it the weekend shot because it lasts about a weekend. But for men, a little bit on the libido side, but mainly what it does is somehow, and I don't think they know the mechanism of action yet, but it induces erections. Like, you're just getting erections all day long. It's kind of a cool thing. But again, it is dose dependent sometimes, and there is that side effect with it as well that turns a lot of people off. They said they can't handle it.
The interesting things about most of these types of the treatment and medications, these effect and effectiveness comes as the side effect. When they were in a trial for something else, they found that the side effect is going to be helpful, specifically for Viagra or Sildenafil. They found that, the side effect is very good, and that side effect helped Pfizer from bankruptcy to go jackpot for the sky. And I think for PT 141, it was the same. And the side effect was increasing the libido for ladies. And I think they started with a kind of a spray, nostril spray, and then they found that injection as more favorable. And that's great. Yeah.
Yeah. Interesting. Well, one thing to consider PT141 is also a melanocortin. So it's one of the side effects, darkened skin. So some patient will notice they have darkened skin as well. So I used to use it a lot until I tried it myself, and I had the nausea and I had the nausea and the flushing. It was not very pleasant. But however, my husband used it and he doesn't have any side effect, even on the maximal dose. So it's very dependent on the user. The last time I used it on a patient, I used it on a 78-year-old man who had prostatectomy and wanted to try it. He actually wanted to try it. I give him like the little tiniest dose you can give, like 0.1 cc, and he still had nausea and vomiting. He was vomiting so much he became dehydrated, had to be hospitalized, had IV hydration. And so you just never know who is going to react to it well, who's not. But in my experience, a little bit different. I have more patients with more side effects than in benefit. So I use it very, very little, and I hardly prescribe any for women because once we balance their hormones, the women do pretty well as well too. So how about you, Chris? Do you use PT-141 quite a bit or not as much?
I for the same reasons you did. It's gonna we get a lot. We have some women that love it, and they'll just say, oh, you know what, I'll suck it up because this weekend I'm gonna have a fun time. I'll just use it for the weekend. But they do get the nausea, vomiting. That's why I tell them you gotta start low on that stuff. Very low doses.
Alrighty, that's great. It was very, very informative for me, and I bet for all of our audience. And thank you so much, Dr. Sandra.
Thank you, guys.
Dr. Trong, for joining me. And yeah, you all have a wonderful weekend and also a wonderful evening for West Coast, wonderful night for East Coast. So we'll see you in our next webinar almost around 4 weeks. Thank you,
everyone.
Bye-bye.
Thank you, guys.
Thank you for joining us in this session of EmCyte's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.